So now let me talk to you about what's new in uterine fibroid embolization, and we've been doing some very exciting work over the last year with robotic uterine fibroid embolization or robotically assisted uterine fibroid embolization. And so why consider robotic uterine fibroid embolization? Well, you know, as I showed you some of the pictures earlier, many times the procedure is very straightforward, and the anatomy is very simple, but we do see all different kinds of patients, and some patients can have a very complex vascular anatomy. In other words, how do we get the catheter into the uterine artery? And if that is complex, sometimes we'll need to use multiple catheters to get into those blood vessels. The procedure will potentially take longer. And when we do that, we'll also see increased radiation to the patient, our staff who are assisting us, as well as the physician. In addition, this can lead to technical failures where we're just unable to get into the artery, although that's very uncommon, it can happen. And sometimes we'll need to put a second catheter, typically not in just the one side of the leg, but we'll have to put a second catheter in the other leg, or bring patients back for a repeat procedure or another attempt. And here is an example of just that. Here's our catheter. You can see that outline here. It's sitting in the main artery before it branches into all these different arteries in the pelvis and the uterine artery. And here on the right, what this case was is the uterine artery made multiple loops. And so getting into this artery can be quite technically challenging. And here's just a picture from one of the companies that manufactures a whole host of catheters, and sometimes we have to try multiple catheters in order to get into the uterine artery. So let me introduce then the Magellan Robotic System manufactured by Hansen Medical. And what is that? This is a robotic arm that is on the side of that table, and you can see it right here, the robotic arm. If you remember that picture I showed earlier of the room that we work in, it just attaches to the side of the table. And then we have a special catheter manufactured by the company, which goes into this arm, and the physician can either sit at a workstation or also work at a table-side control where they're controlling that catheter. The catheter doesn't just work on its own. The physician controls the catheter, and with this one catheter we can make multiple shapes. And here I'm going to show you a short video which shows the Magellan robotic catheter in action. So if you remember from the picture I showed earlier, we put the catheter in at the top of the one leg, and then we can navigate the catheter into the artery that feeds the uterus, and specifically the uterine fibroids. Now, patients have arteries on both the right and the left. We deliver the catheter on this side into the right uterine artery, and then we inject our embolic agent to block the uterine fibroid, and we use the exact same catheter to navigate to the other side into the left uterine artery, and we just use this one catheter, and we could put different shapes on it where we're going to deliver the embolic agent into that left uterine artery, and once both arteries have been blocked, the uterine fibroid is going to die and then shrink. And here, just showing you here, is a picture where I'm sitting at the workstation controlling the catheter, and you can see here the table. We have staff that are attending, standing by the table, and I can actually use this workstation to drive that catheter into the uterine artery, and we're looking at live X-ray feed here. So here's one example. This is a 37-year-old female who had severe menorrhagia, which is heavy menstrual bleeding, dysmenorrhea, which is pain, and urinary frequency. And she had actually had a history of 2 prior myomectomy surgeries. So this is a picture from her MRI. Here is a very enlarged uterus with multiple uterine fibroids. You can see this white down here is the bladder, which is completely compressed by this. The fibroids are bordering this inside lining of the uterus, and that's probably causing the heavy bleeding. Here's the same patient, a view from the side. Here's the enlarged uterus and the uterine fibroids, and you can see here that bladder that's completely compressed. So we'll use the catheter, and here's just pictures from the catheter. We have an X-ray here of the pelvis. The patient is on the special angiography table where we're using live X-rays, and we put the catheter in the artery at the top of the leg here, and then we can navigate the catheter and we know where the blood vessels are, and you can see this catheter coming down. In this case, it's coming into the left uterine artery. And then we inject the X-ray dye, and here we're going to see this very enlarged and twisty-turny uterine artery. We get our catheter directly into that uterine artery. We inject the X-ray dye, and this is the big blood vessels that are surrounding the uterine fibroid. And through that, we're going to inject the embolic agent until we've done that. And here are all these other normal arteries to the rest of the pelvis, but there's no more blood flow going into the uterine artery on that side. And then we retract the catheter into the right uterine artery, which is going to be down here, and we navigate that just like that. Into the right uterine artery, we inject the X-ray dye, confirm exactly where we are, and then we're going to finish the embolization. That catheter is going to come right out. And then we do a final picture to make sure that all the other blood vessels that we want to stay open are open, and the ones that are feeding this pelvis and the uterine fibroids specifically are now closed, and there's no blood flow going to that those multiple fibroids. So in summary, the use of the robotic catheter has actually allowed us to have increased predictability of getting into the uterine artery with just one catheter system. We have a lot of stability of the catheter for these procedures where when we put it where we want to have it, it stays. This minimizes the catheter exchanges in these very complex cases and therefore avoids technical failures in our ability to succeed at the procedure. And as I said earlier, although that's very uncommon, it can happen. And certainly one of the most exciting things for us is that we're decreasing radiation to the patient, our staff, as well as the physicians performing the procedure. And with that, I thank you very much.